Has anyone else welcomed you to CUGH 2024? You guys are amazing. 8:30 in the morning. This is a big room. I do encourage folks to come forward if you are so brave. Even if you want to leave, we won't hold that against you. So my name's Adam Richards, and I'm joined by my colleagues Ravi Goyal and Parveen Parmar. Unfortunately, one of our colleagues from Bangladesh was unable to make it today. If you guys have questions about what's happening in Bangladesh, we can answer those, but we won't have a formal presentation from that part of the world this morning. So we're super excited to share our experience about cardiovascular disease treatment in humanitarian settings, right? And each of us brings, a lot of, many years of experience working in the field, but more recently have moved to focus on cardiovascular disease. So I'm an internal medicine physician and health services researcher. I was here in LA, I grew up around here and was at UCLA for over a decade, but a few years ago moved to DC where there's a lot more work on humanitarian work. So I'm at the Milken School of Public Health at George Washington University, and one of the main faculty in the humanitarian health program there. None of us, have any conflicts of interest to declare. It's always nice to start with a little bit of a story, and as I've gotten into doing CBD work in conflict and running trainings, what we often do is ask people their personal experience, right, with cardiovascular disease. Like, do you know anyone who's had a heart attack or a stroke? Because it's typically a little bit neglected, right, in the humanitarian sector, as we'll be talking about. And I can ask that of you now. So, do you know anyone who's had a heart attack or a stroke? If anybody's not raising their hand, consider yourself lucky, right? Because, as we'll see, this is a major challenge. And even in the most remote settings, it's just unanimous, right? Everybody raises their hand, and they can start sharing their stories of the people who are hemiplegic, paralyzed on one side, and whose lives have been lost, right, to cardiovascular disease. And that is the beginning of a conversation to say, well, maybe we should begin to start caring a little bit more about what ends up being the #1 killer around the world. So we have an hour and a half with you, and we're going to not overextend our comments so that we have time, to have a nice conversation. But some of our goals, and I'd be interested to hear yours, right, are to understand a bit about the burden and the inequities of cardiovascular disease risk factors in displaced populations, and learn how different care models can overcome the challenges in, well, it was initially going to be 3 different settings, but now it'll be 2, namely urban and remote, rural, internally displaced person settings. And then this panel today is really focused on different methods that we can use to, right, develop and then test interventions to reduce cardiovascular disease and CVD inequities in humanitarian settings. But I think these tools can be used broadly, not only for other conditions and diseases in humanitarian settings, but also, right, for more stable settings in global health more generally. And so we're going to be talking about how to take complex health systems and understand them better and see why different interventions are working. And we're also going to look at how to quantify the impact of multiple interventions to reduce cardiovascular disease, summarize health inequity, and then take that concern for equity into account, even when we look at cost effectiveness, right? In unstable settings where people are moving around all the time, how do you conduct a randomized trial? So adaptive study designs end up being pretty useful, and if you want to try to budget and plan for these things, you have to have a sense of how many people you need to recruit. And so Ravi's going to talk a little bit about sample size as well. So Adam, I'm doing the introduction. We're going to turn to Parveen to talk about Syrian refugees in urban settings of Jordan. And then, again, unfortunately, won't be able to talk about the camp-based setting in Bangladesh. And then we'll come back to me to introduce internally displaced people in that program in eastern Myanmar. And Ravi is going to finish up with some additional comments from our project in that setting. And I should say we all are funded on a study from R2HC, which is one of the unique funders of research in humanitarian context on a cluster randomized trial in Eastern Myanmar, and that brought us together. And then hopefully we'll have a lot of conversation from you. So a few more pieces that I'll add here in this introduction, right? It's just for those of you who aren't humanitarians in your day-to-day jobs, right? We'll talk a little bit about forced displacement and the cardiovascular disease burden and different approaches that people have started to pilot, right, and test to treat cardiovascular disease in these settings, right? So there are now over 110 million people, right, who have been forcibly displaced. If you can see on the yellow, right? Here we are in, does that work? Oh, it does work. See, there you go. Now, this doesn't take into account the several million, right, in Gaza. So maybe you'd say 112. So that's a lot, but China's like a big place, right? There's a lot of people in India. Where would that rank in terms of a country, right? If you took all the forcibly displaced people and called them a country, well, it would be about, the 15th largest, right? In Europe, though, it would be the largest country. For some reason, Wikipedia puts Russia as part of Europe, but without commenting on that, it would be, right, the largest country in all of Europe. So meeting the Millennium Development Goals, if we ignore people who have been forcibly displaced, that's going to be a little bit tough, right? So everybody knows what is the number one leading cause, right, of removing humans from life on this planet? Cardiovascular disease, right? And it's been that way since 1990, right? So nothing new there. Now, in low-income countries, not lower middle, right? So in 1990, that was not the case, but of course, that is the case now. And many, right, settings that experience war and conflict are in these low-income settings. But let's look specifically at Syria, right? Well, Syria, as more of a middle-income country, before that war started practically a decade ago, right? Then has, experienced this burden that went through the epidemiologic transition earlier than the other, low-income countries. But even in Myanmar, right, cardiovascular disease and stroke leads heart disease, number one cause of death. But maybe you're like, well, everybody's got to die sometime. Cardiovascular disease happens, to older people. I care about disability-adjusted life years, right? Over the lifespan. I really want to take into account, events that remove children, like early in life, right? This is something that's more important to me. And in 1990, cardiovascular disease would not have ranked as your top priority. And globally, in low-income countries, right, it moved up, but only by a couple slots, right, to number 6. But if you look at Syria, right, even in 1990, it was number 2. And now, right, it's number 1 as a cause of disability-adjusted life years. How about in Myanmar? It had a, whoa. That is.
Make it full screen.
Yeah. That is really strange. Sorry about that.
Yeah, that's right. That's right.
All right, guys.
Someone's watching.
Let's see. Maybe I will unplug the dongle.
Oh, but it looks like it's actually the projector.
Oh, it's the projector. Yeah.
Is it projector?
It's the projector that's blinking.
Okay.
Adam, if you look straight ahead.
Lifeline to the back, guys. I'm going to do it different. Yeah. Yes, I will change that. So, I like to browse a kiosk. So then, all right. Well, I can keep bloviating for, who needs that? So for disability-adjusted life years, right? Even in Myanmar, which is way behind Syria or was before, the conflict. Number one cause now, right? So it's both the number 1 killer and the number 1 cause of disability-adjusted life years. So what, has the humanitarian community done, about this? Well, historically, it's been pretty low priority, right, to treat cardiovascular disease. We've prioritized, acute infectious diseases, younger populations, and kind of thought, well, most people in crisis, it's like an acute crisis, and then they can kind of get back into their lives and reintegrate. Most crises don't last that long. Well, it turns out, of course, that practically 3 in 4, right, would experience forcibly displaced people are in so-called chronic crises, which, for better or worse, is the threshold of sort of 7 years, right? So most people are in protracted crises that are going on for a long time. And so the luxury of just ignoring cardiovascular disease ad infinitum, right, is probably not there. If you really care about saving lives and you're ignoring the #1 cause of death, you might want to ponder that. But so, historically people have said, well, this can be part of the package of care that you provide, say, at the clinic for people who show up, and then you happen to either pick up that they have cardiovascular disease, but screening people is not really a priority. It's more like people who were already on meds, and then they're coming and asking for treatment, and then, okay, we're going to try to, take care of you. Models for longitudinal care have been lacking for cardiovascular disease. Are they possible in humanitarian settings? We know they are, right? How do we know they are? When you invest in something like we have in HIV, where you have to take a pill every day for the rest of your life, absolutely you can do this. It's just, where there's a will, there's a way, right? And where there's money. I love, you're using your imaginations. I like that. Sometimes it's good to liberate yourself from PowerPoint, All right, so, and Syria really, right, more than any other crisis, put cardiovascular disease and non-communicable diseases in general on the map, right, for the humanitarian community. Because it's a middle-income country. I mean, there has been historically malaria, right, in the Mediterranean region, and you can look at people's red blood cells and see thalassemia and the selective imprint of that disease over the millennia. But now it's not really a problem. They're not dying of the infectious disease as much as they are of chronic disease, right? And they're living in urban settings, and like now UNHCR has to take care of that. What other big conflicts? So the displacement of Venezuelans, similar, right? Ukraine, they're not dying of the infectious diseases, right? Even Gaza today, right? Yep. We have. So the donors, though, right, have yet to catch up to this fact. And so part of the reason for generating an evidence-based, in addition to the accountability to beneficiaries, right, would be to generate the evidence base that can really convince donors to put more money and effort behind this to support all of us who do this work. Forcibly displaced populations, by definition, right, have been forced to flee and show up somewhere else, but the imprint of cardiovascular disease is in their bodies, and that comes with them. This is not something, they leave everything else behind, but they don't leave behind, right, their chronic diseases. So again, for those less familiar with the humanitarian sector, one thing that's kind of nice, and wouldn't it be nice actually if the entire global health community had a document similar to Sphere, right, which is based on a foundation of human rights and translates human rights obligations into minimum standards, right, that we are obligated as the international community to provide to who? Every human being on the planet, right? So if you have a large burden of disease, right, like cardiovascular disease, what is the obligation that we would have? So unfortunately, the most recent iteration of Sphere does mention cardiovascular disease, I believe, for the first time. What it says about it, though, is fairly limited, right? You have to have facilities, medicines, equipment, and the people to provide those services, but it doesn't really say a whole lot about how you should go about providing that. It doesn't say you really need systems to provide that continuity of care. It doesn't really say that you need to bring that care out to people as opposed to having the people come to the services in the facility. A more recent development, very welcome, right, is to adapt the WHO PEN protocols for non-communicable diseases to humanitarian settings a little bit. This is a step in the right direction and says community health workers can get involved largely by doing, counseling. And so briefly to talk about a few, lessons learned actually from outside the humanitarian sector that may or may not apply, right, in areas of conflict. There's a growing literature, right, on the effectiveness of community health workers in stable settings. And so I'm not going to go through all this. There's a lot here, right? But we are moving from traditional models of facility-based, right, physician-driven and disease-focused programs, right, into more holistic and community-level interventions that bring these services out into communities. And this has been shown in, nice cluster randomized trials from China, Indonesia, Colombia, Malaysia, Bangladesh, Pakistan, and Sri Lanka. And now we're beginning to see some evidence emerge, right, from humanitarian context, but people are using a whole bunch of different models, and it's a bit of a wild west, but MSF really had some nice experience in Jordan, as did IRC, and Parveen is going to tell us more about that project. Medical Teams International had a very small pilot in the Bangladesh camps, but they lost a third of folks to follow-up. So there's some questions, right, that remain that we will explore in the rest of today's session. So what tools, right, are there that assist us to develop and adapt interventions to local crisis contexts? And how do we engage these stakeholders to build that political will and hopefully the resources, right, that'll help us do a better job? And how do we test whether a care model is effective or not? And if it is, why is it effective, right? It's implementation research. And if clinical services are rarely used, like in Eastern Myanmar, how can we increase that utilization by actively reaching out and screening population? And then how do we measure the inequities in cardiovascular disease, and if they're present, how do we ameliorate them and reduce them, even in conflict settings, right? And if we care about value, because there's never enough money in the humanitarian sector, right? Donors often care, as do we all. We want to, do the most we can with the money, we have. How do we take that and our concerns for equity and bring them together, right? Because we, theoretically anyway, prioritize both, but we rarely empirically do so. And then we'll look at different adaptive study designs, for very unstable settings and the number of people that we need. So now I'm going to turn it over to Parveen to talk about Syria. Oh, there we go.
Thank you. All right, good morning, everybody. Thanks for showing up again at 8:30 in the morning on a Friday. Really appreciate it. If I weren't presenting, I 100% wouldn't be here. I kid. I'd be here for your presentation, absolutely. So I'm going to be speaking a little bit about our experience using causal loop analysis to inform the development of an improved CHV intervention to manage diabetes and hypertension among Syrian refugees in Jordan. This was a project that was also R2HC funded. This was done in collaboration with, well, I should first mention my co-PI, Marwan Retnayake, who's not here today. This is his slide. But also, better? Okay. But was a collaboration with IRC and the Jordan University of Science and Technology. There's a fantastic community health nursing program there that we worked with. And I'm from the CUGH School of Medicine. I should say I'm an emergency physician. I'm actually the director of academic programs at the Institute on Inequalities in Global Health here at the CUGH School of Medicine as well. And I will get started with presenting. So, several challenges with managing non-communicable diseases in conflict-affected settings. We've talked about that a little bit. Adam has gone through it. Health systems are complex adaptive systems, right? They're constantly changing. They're linked by feedback and adaptation. One change in one part of a system can result in unintended consequences in other parts of the system, or face unanticipated barriers. The one thing about cardiovascular disease that's critically important in terms of management, regardless of where it happens, is a longitudinal healthcare system of some form, right? This is not a one and done situation. This is not, treating something infectious and then, an infectious disease and then getting them better. So when you're thinking about a humanitarian intervention to manage NCDs, you really have to be thinking about how to strengthen that longitudinal system. But how do you do that? So we take, treating, is anyone here an internist or general doctor that manages diabetes and high blood pressure? Yeah, challenging enough in a stable setting, right? Like throw in conflict, throw in, challenges with security, challenges with, finances, getting adequate food, being able to leave your home to do things like exercise if you needed to, all of those things, and certainly it becomes really challenging. And then, of course, there's, the health system is often really threatened for a lot of reasons. So how do you take that into account when you're planning an intervention? And how do you ensure a comprehensive view of that system in a humanitarian setting? And I'll speak for myself, and I think most of us would agree that with the best of intentions as public health professionals, we don't always do the best job of getting a comprehensive view of a system. Is that a fair statement? Yeah. We often, with really great intentions, plan an intervention, and then something happens that takes us by surprise, right? And then you've got to adapt to it. So the idea is, how do we address that in advance? So let me talk a little bit about the context first. Has anyone either from the region or work in the region, Jordan or Syria? Okay, great. So you'll correct me if I get something wrong. But essentially, we worked with Syrian refugees living in Jordan. The project started in 2018, ended in 2021. At the time, the numbers were somewhere between 600,000 to 1 million refugees, primarily located in the north, but also in kind of urban settings and also in the capital. They, as throughout the region, had very high rates of diabetes and hypertension. So before we started our intervention, the first step was actually a community survey. So we went to all of the different parts of the IRC catchment area and asked a variety of questions in terms of access to medication, last visit to a provider, et cetera, but also did some screening, measured a blood glucose, measured a blood pressure. And up to 40% of people had evidence of hypertension, not diagnostic, obviously, because of the diagnostic criteria, and as many as 20% with diabetes, right? So this is a major problem. I think everybody knows that. And this is a photo of the region that we were working in. So this is Ramtha. So there are 2 clinics that IRC had. One is in Ramtha, one is in Mafraq, and you can see kind of very close to the border here. In terms of the health system that the Syrian refugees had, so when the refugees first came over, they had access to Ministry of Health clinics, free access. And then later that was taken away. And then later it involved a fee. And there were a variety of NGOs. MSF had a fantastic NCD program, but unfortunately were only able to accommodate a specific cohort. So if you were in the cohort, you got amazing care, but they weren't able to extend it out to other people. And if you're looking for an example of a really incredibly run program, Iveen Ansbro actually published a bunch of work on NCDs and management through MSF that's really worth reading. But there's also IMC, there was IRC, so there's a patchwork of NGOs also, and also regional NGOs trying to provide care to this really high needs population, and then complementing the ministry. So you can imagine what that patchwork looked like and what patients' experience was in navigating that. Really, really challenging. Transportation, all the barriers you would normally expect, right? Transportation costs and medication costs, and we'll get into some of that in a little bit. So when we were thinking about the best way to sort of gather information about this complex adaptive system, causal loop analysis came up as an option, and I hadn't been familiar with it before, actually. So causal loop analysis is another great example, I think, of how public health kind of has and should continue to get really good ideas from other industries. So systems dynamics analysis comes from engineering. Causal loop analysis is sort of derived from that. And it's basically, causal loop diagrams basically depict these very complex systems. And the idea is that you understand a context in the health system from a variety of perspectives. The idea is then if you plan an intervention, you can sort of model it out and you can start to think about what the unintended consequences might be, but you can also really start to understand where there might be hidden opportunities for success. And you can develop programs in kind of a very concrete and explicit way with multiple stakeholders from kind of a variety of levels, and I'll get into that in a little bit. Now, this has been used in many public health contexts before, so health system resilience in Nigeria, neonatal mortality in Uganda, immunization in Kerala, and a variety of others. And I'm very happy to share references with anybody that is interested. So this is a very simple example of a causal loop diagram. It's really quite intuitive. So as you can see, you have an outcome of interest in the center, Here it's the population. And then you have variables that contribute to that central outcome. So in this case, we have births and we have deaths. And then you have these arrows. And if births, as you can see, have an arrow leading to population with a plus, and deaths have an arrow leading to population with a minus. Pretty intuitive, right? Now, these little hashtags up here basically indicate a delay. The R stands for a reinforcing loop. So as births go up, your population goes up, and then your births go up, right? And then, of course, a balancing loop, which means as population goes up, deaths go up, population goes down, etc. Pretty good? Questions? Thoughts? Okay. So what we did was we basically took this concept to the field, to Jordan, and worked with our colleagues there. The central outcome was the health of patients with diabetes and hypertension, Syrian refugees, and vulnerable Jordanians living in IRC catchment areas. And so defining that boundary of the population you're dealing with, defining your central outcome is really important. And then we identified all of the variables that relate to that core problem. Once you have those variables, such as your births and deaths, the equivalent, you get a mixed stakeholder group and you draw your diagram. Now I should say, the way this is done, so one of the people who initially supported kind of my journey in learning a little bit about how to do this was a USC faculty member here, and the way that she had used it was actually creating a multi-stakeholder group and meeting with them over time. I think that is the best way to do it. It's a little challenging to do in some settings for a variety of reasons, but what we did was because we didn't have the luxury of meeting with this group over many weeks or many months, we started with qualitative interviews of multiple stakeholders, so representatives from UNHCR, WHO, donors, patients, are critically important, doctors, front clinic staff, community members, community leaders, and conducted these and then kind of drew our variables from those interviews. And this again is the central outcome that we were talking about. So I'm gonna go, I have a little bit more time, so I'm gonna, I don't have it. Oh yeah, there we go. Okay, so these are some of the variables that we came up with. So from the key informant interviews, some on capacity and access, so things like longitudinal patient access and utilization of the primary healthcare package, patient access and utilization of secondary and tertiary care, capacity of the health system, obviously critically important. If people are seeking care, you want to make sure that that capacity is there to meet it, and then stable financing for health programming. I'll show you in the causal loop diagram later, the variables, the way they were pulled out, we sort of had some that were higher level policy, then sort of at the clinic level, and then at the patient, sort of the community health worker level, and then the patient level. So you can kind of diagram it out in a way that you have a sense of kind of, I don't want to say hierarchy, but sort of the levels and kind of the ways that they interact. Another key obvious issue that came up was coordination. So with that patchwork of services, how do we deal with duplication of services by health actors as a way of, sort of avoiding waste of the very kind of precious resources that were in the region? How do we improve coordination between health actors, and then provider access to health information across health systems? Patient perspective, really important. How are they perceiving their health services? Coping strategies. So, borrowing medications from neighbors, using a one pill for your hypertension every other day to make it last longer because you can't pay for it. Capacity for self-care and health literacy. Mental health of patients is a fantastic paper by Ansborough on the link between mental health and non-communicable disease. And then, one important variable to think about in the system is what's your undiagnosed burden of disease, right? So, many of the people coming from Syria had, relatively good access to healthcare previously, so many of them knew their diagnoses. In a setting like Myanmar, where there's been sort of really limited access to healthcare, that healthcare system's been pretty decimated from the longstanding civil war, many of them don't know, so that burden can change a little bit. Out-of-pocket expenses and mobility of patients, so disability being a major issue in getting access to care. And then we honed in on, from every perspective, what were the variables related to the CHV program that were going to be important? Now, Jordan is a very, their medical care is excellent, right? They have incredible specialty services and beautiful tertiary care hospitals and really, a lot of available services. The community health piece is a little bit less developed. And actually there's some resistance, I would say. For some people they feel like, just based on the group we were speaking to, I can't speak to a broader group, but some people were like, this seems like, this shouldn't be in a healthcare system that's as sophisticated as ours. But, the important piece here was, how do we pull out the barriers that we see here, and how do we coalesce the group around, how can a community health volunteer model actually meet those barriers and actually help the patients? And so we talked about, improving their technical capacity. We talked about the policy, the policy environment that would support community health volunteers. We talked about the kind of roles they could take. So I will leave it at that, and we can talk about it a little later. So the workshop. So what this looked like is we did these qualitative interviews. You do your traditional analysis, pull out your variables, and then we had a multi-day workshop in Amman, where we invited everyone that had participated in the qualitative interviews, plus a few other people. And the first thing I did was, we just had a lot of discussions about, do these variables look right? Is there something we're missing? Is there something you'd like to edit? And the languages were, English and Arabic, right? And you can imagine in some contexts you're going to have even more languages than that. So that was another kind of challenge, a practical challenge. And then we actually broke everybody into small groups. And we said, here are your variables. Start to think about, from your perspective, what does the system look like? And you can see here's a group of our, our research coordinator here is in the group, and then one of the physicians. And so it's a mixed group here, and patient. And they just sat together and they just drew lines around these variables and drew this diagram. There's something that happens that makes people interact differently when they get out multicolored pens and draw. It's really great. But everybody had a different perspective on the system. Everybody had a different perspective on what was important. And then we worked together to build this broad diagram. Now I will show you a photo of the diagram, and it's quite complex. So you can see though here that you have, like I said, you have the policy level at the top, you have the health system level, the community level, and the patient level, and you have all of those variables that we drew from those qualitative interviews. I've definitely had people say to me, how could this possibly be useful? And it's a valid point. It's a very complicated diagram. But if when you're developing your package, I think that looking through this and kind of thinking through, where might these levers affect the system can be useful. But here's what I found to be the most useful thing. This process built community, and it built multi-stakeholder engagement. It built a group of people that were really invested in sort of getting to that central goal from their perspective. And we developed a lot of buy-in from people that sort of had the questions about whether this intervention was going to be valuable. So it built something really strong, which was kind of nice. And it builds a group of stakeholders then that you can later engage when you're doing your dissemination, and you can come to for advice, which was also great. Limitations. The traditional engagement over time is challenging in a conflict setting, and certainly in a research setting. I think if you can do it, if you have the time to do it, it's great. In my experience, it's really been that sort of mixed qualitative and then diagram building method that has worked the best. The other thing is that this causal loop analysis concept is a little challenging to absorb, so it does take some time. So you have to figure out ways to sort of get people on board with what you're doing earlier. And then this process involves sharing opinions that people may not agree with. You might have to be a patient and say to somebody else, actually, what you're saying about that policy that's available is not right. That I'm not able to get that service at that clinic. I am not. And culturally, that works well in some contexts. I think one of the really beautiful things about the Syrian context is people do have a really strong voice for the most part. It was really just incredible community members that I got to engage with. That's not, in other cultures, it might be really challenging, so then you have to figure out creative ways to get that, and it really, frankly, may not work. So that is my presentation. Thank you so much for your attention. I appreciate it. Look forward to your questions.
All right. Thanks, Parveen. So now we're going to switch over to Myanmar. And you get me as the intro. I've been working for over 2 decades in Myanmar. And Ravi has worked on another project, but asked me to do a bit of the intro, and so I'll be talking about some of the quantitative methods that we're using in this exciting randomized controlled trial. So with the idea, each of us, I guess, has our own presentation, so the rule of you can only remember 3 things applies to each of us, right? So then you can remember 9 things, maybe. So the 3 things, right, is that, trials that you're conducting, right, you should try to quantify the benefits of treating multiple risk factors for cardiovascular disease, right? Because if you're seeing a patient and they have, these risk factors cluster, you're not just going to treat only their hypertension. If they are eligible for a statin, you're going to give them a statin. And so we should design trials that way and not just have one outcome, because that's not how human beings exist and how human beings treat those human beings. And then, we should always, right, routinely study which interventions reduce inequities, right? They are ubiquitous, even in areas of conflict. Unfortunately, we often are blind, right? And we do not know which interventions are progressive and the benefits accrue to those who are less well off, and those that are regressive, that concentrate disadvantage among those who already are disadvantaged, right? And then the third point would be that tools do exist, right, to take equity into account when you're doing cost effectiveness analyses, and most stakeholders really do prioritize both equity and efficiency. And so these are the partners. The folks not represented here for matters of security are the Ethnic Health Organization that is the implementing partner in the conflict zone of Eastern Myanmar, and then Concurrent University, which is a Thai university. And because the universities in Myanmar are basically not working now, then this is our local or regional representative. The study area, if you look over here, this is Myanmar, this is Thailand. I've blocked out the names, but it is the catchment area of 6 clinics, and ultimately maybe 1,700 folks with high cardiovascular risk or hypertension, we expect it to have. And you can have typically, so this one actually is a little more central, but you have one clinic village, right? And then a bunch of other villages that are at varying degrees of remove from that area, right? And how do you deliver services here? Like if you are a patient over here, right, you have to go through 2 other villages. You got to go, maybe by bike and car over here. You got to cross the river. This is like going to grandma's house. And it is not going to be easy for you to show up on a regular basis all the way to that clinic once you introduce this variable of insecurity where people could be blocking this, not safe to cross over here, being on the road that is part of the connection here, that you're not able to go certain parts of the day. You want your refills, forget about it. So to give a little flavor, right? I mean, you got sometimes more like streams that you can maybe walk across, but a lot of them, particularly in the rainy season, right, become these huge rivers that, you need a boat to cross, and you're pretty visible out there, and then the roads become pretty impassable also in the rainy season, right? And this is typical of lots of low resource settings. You don't have to introduce the variable of of conflict. So if you're going through all that effort, right, to either bring the service to the people or to bring the people to the service, are you going to treat one risk factor? Of course not, right? That just defies logic, right? So how would we go about that? So it turns out for a couple randomized trials that were done to reduce stroke risk here in LA County, we developed some models, an approach that is pretty simple, but to model the impact of treating multiple cardiovascular risk factors. In that case, it was on stroke, and we also looked at cardiovascular disease. So this is adapted from a table from one of those papers published a couple years ago. So this is, and it's a little bit of a simplification, right? So if you treat systolic blood pressure, right, and you get people to take a statin, you can reduce, right, the risk of having heart attack or stroke by say, it depends on age here for blood pressure perhaps, but 40% and 20% for each, right, millimole per liter of cholesterol that you reduce, but potentially 40% by taking a high-dose statin, and if you're a smoker and you quit smoking, by another 20%. So these risk reductions are multiplicative, such that if you have 3 of them in a row, this guy quits smoking and ends up taking, the medications, you're cutting their risk by more than half, right? Nearly 3/4 or 2/3, right? You're treating multiple risk factors, addressing them all at the same time. If you just did one, you wouldn't get all the way there. And you can then use this approach to estimate. You're not directly measuring, right? Very few trials are powered. They don't have enough sample size or duration of follow-up to accumulate and observe, right, the hard cardiovascular events of actual strokes and heart attacks, right? So these methods, this is one of the methods that we're using in that study. So another one, right, is to look at inequities. So before doing this study, there was a very large DHS-style survey that for the first time in 2019 actually measured cardiovascular risk factors, right? It was a pretty large study in eastern Myanmar. Smoking was very common, right? I mean, half of adults over 40 smoked. And hypertension was undertreated. This is the hypertension cascade. So if you take everybody who has hypertension, right, those who are meeting their goal, certainly, less than half, and overall, cardiovascular risk was fairly high, and it was unequally distributed. So let's focus a little bit on smoking, which is here in orange. Does it show up? And gray, which is folks at elevated cardiovascular risk, by which we mean greater than 10% risk of having a heart attack or stroke in the next 10 years, based on the WHO, right, CVD risk prediction, equation. And so if you have no schooling and you're illiterate, or this one should be schooling and illiterate, and you go all the way up to those who've completed high school, there's a large gradient, right, in cardiovascular risk. So, much of that is driven by smoking. So this is even in this, remote setting, in rural Myanmar. So what are you going to do to both treat overall cardiovascular risk and reduce those inequities, right? How will you go about evaluating your intervention? So usually, right, we don't care about who is benefiting and who is not. We look at, some people call it the tyranny of means, right? The tyranny of averages, where you're looking only at the average effect of your intervention, right? And so here, if you had 2 different interventions, A and B, and they both reduce cardiovascular risk by 30%, they look kind of the same. But wouldn't it be nice to know if intervention A actually exacerbated, right, things for those who were worse off, right? Say below, this is now income, but and a simplified dichotomous, right, outcome, not a gradient, but made things worse off for those who already had less, and really all the benefit was concentrated among those who had more, right? Versus B, where you have a much more equitable distribution, right? You have probably narrowed, the inequity is less, even though the average effect, right, on this blue line is the same. So most of the time, we don't look at that, right? Oftentimes, it's not always so clear cut. You don't make things worse for one side, but nevertheless, there could still be a differential impact on the inequity while, say, having the same average effect, right? So here, A and B, there's a larger inequity in absolute terms, 20 percentage points for A and 10 percentage points, right, for B. So the strictly utilitarian, right, value system would say, we don't care who benefits, right? And again, this is how most trials are designed for most interventions, including, right, somewhat ironically, even in humanitarian settings where this rights-based approach really requires us to focus first and foremost on those who are least well off. You might say, right, a rights-based approach should create a duty to look at the distributional impacts of what we are doing so we are not exacerbating inequities. And I would encourage all of you to take up, some of these methods, and I'd love to talk with you more after this about how you can do that. All right, so It's important, though, as we talk about inequities, not to lose sight of the fact that, some interventions that reduce inequities more just aren't as good, overall, right? And, but it doesn't necessarily mean that you always go for the one that just has the greater average effect. There's going to be trade-offs, right? So here we have intervention B has a greater absolute risk reduction, but the inequity difference, is the same. So because the entire world can be, understood by a series of 2x2 tables, or, two different axes on a two-dimensional plane, right? We can call this the achievement plane, right? And so up here, everybody's happy. Why? Because you've improved health, you've decreased cardiovascular risk, and you've addressed the inequity, right? If your intervention lands you, so if you start with, compared to intervention A here and intervention B here is more progressive and has a greater, impact overall, then everyone wins. Here, isn't it nice to know that the less effective intervention is also regressive, right? And does not, and exacerbates the inequity. But, in these two quadrants, right, you have to make some trade-offs. You either, focus on improving health overall, accepting a bit of, an exacerbation compared to, say, intervention A, if we put that here and then we're comparing intervention B, right? Then you could say, well, we're gonna sacrifice a little bit of that equity, because of the benefits for effectiveness, right? And here's the other way around. You would prioritize inequity. What's the right answer? There's no right answer, but different people will have a different slope to this line where, like, everything over here is good, and you're going to go for that, right? If B falls on this side, and if it falls on this side, you're going to go for A. Clear? So there are quantitative ways to place the points in these different quadrants. For matters of time and setting, I'm not going to go into too much detail, but if people are familiar with the Lorenz curve and the Gini index, which we use to measure income inequality, there is an analogous term called the concentration curve and the concentration index, where you replace, this keeps going away, you replace income by the health outcome, and you still rank people by education, income, whatever the ranking socioeconomic variable might be. And so if you go back to that slide with the gradients for smoking and cardiovascular disease risk that I put up, then just the values that come out are this. They are highly significant. This is actually quite large for smoking, a little bit smaller for CVD risk, and you can translate this as it is related to the proportion of the population that you would have to move across the median in order to achieve, equity. And this is on the, your eyes have glazed over. I've seen that. We're not going to talk about the equation, right? But it is important to understand that we need to, right, capture relative inequity, which is what we've been talking about so far, as well as the absolute inequity. And best practice would be you look at both. The relative concentration index is what we were talking about, but when you are thinking about health achievement, again, that's the achievement plane, you actually can combine these two things, right? By saying this is your mean health mu, and you take the complement of the concentration index. Don't worry about the details, but to say the achievement index, right, is like an equity-weighted measure of whatever health outcome you're looking at. You can look at health utilization this way as well. But it is a way to quantify this, and you can take that value then and plot it, against, plot the mean health and the absolute concentration index. I have only one slide on this last one because it gets, even a little more complicated. To say there is an analogous approach, right, to look at equity and efficiency trade-offs. So, before, we're talking about just the effectiveness of something. We're not taking into account how much it costs, right? So efficiency and cost effectiveness analyses would say, okay, this is the total benefit you get, the cumulative impact, right? The average effect sort of multiplied by all the people, and this is how much it costs, right? Overall. And it, again, is naive to and indifferent to who is benefiting. You can take the same tools for the achievement index, which is the equity weighted measure of, right, your effectiveness, and then take cost into account and do, have play a similar game, again, on a different 2x2 table, right? Here we are, where here you're gonna say, wow, like, there's no question it's worth it, because the more efficient, the more cost-effective intervention is also the most progressive, and so that's awesome, right? Over here, it's more cost-effective, but oof, it exacerbates inequity, and you're over here. If you can get 100 people in a room, hopefully 90, somewhere in the 90s, people will say, yes, they care about inequity at least a little bit. But for all those who raise their hand and say that they care about it, you're gonna get just about as many different answers about how much efficiency they would trade off for that equity. The nice thing, and I'm not gonna go into it here, is that these methods also accommodate these different attitudes, right? So you can say, I'm one of the, hopefully few, maybe in this room few, people who don't care about inequity. I just wanna maximize efficiency, that's it. I don't care if it's already the people who have everything and they get all the benefit, that's fine. You can make that case, that's totally fine. That's not, there's a lot of utilitarians, there's something to be said for that, right? That's not totally ridiculous, and it happens to be the default way we look at things. But then you can have, people care more and more about equity. Some people get pretty extreme, like, if anybody is the least well off, like a true Rawlsian, then we should go for that, even though you're sacrificing benefit for a whole lot of people, right? We make these efficiency trade-offs all the time. Dial back, right, to the rural area. I mean, the people who are harder to reach are harder to reach, often more expensive to reach, right? But nobody says, well, just because it costs more doesn't mean that, their right to, public and clinical health services just evaporates. No, we're gonna invest more. But how much more should you, at some point it becomes, the marginal benefits are totally, outweighed by that. This is a way of quantifying, taking a quantitative approach, right, to these equity efficiency trade-offs. And so we're using these tools in our trial. And now I'm going to turn it over to Ravi.
Well, thank you everyone for coming, and thank you Adam and Parveen for those. And so I sort of thinking about what has been presented, I think they kind of end up in the two ends of a study, the beginning of it on design and coming up with the intervention, and sort of the end of it on thinking about analysis and thinking about distributional cost effectiveness and what you can do sort of with all the output and all the analysis and inference that has been done. And what I'm going to sort of talk about is that sort of middle area of thinking about the research methodologies in complex settings. So thinking about study design and about those kind of considerations. And so in these complex settings, whether humanitarian or conflict or different areas, the evaluation design needs to be aligned with the program implementation and context. So definitely throughout this conference, there'll be a lot of discussion about how to make sure culturally the intervention is the right one, how to make sure it's acceptable, and those are extremely important considerations. But then on the other hand, you have to kind of achieve these other considerations without losing the rigor. And that is a huge sort of challenge that is placed on these different studies in these settings. And this is going to be a little bit of a different talk on that I usually give. Is going to be a little bit of a I should have paused and introduced a little bit about myself. So I'm a biostatistician, and so I work a lot on the data analysis, and I got the great pleasure to be working with these lovely folks for about 15 years or so on doing a lot of data analysis. And so this is a little bit of some of those thoughts over those 15 years is what this presentation is going to cover. And so this second comment is really about, I'll sort of say, about my discipline. And so it's really regarding the study design and thinking about the statistics and the methodology that there was a review paper in 2019 that looked at all of the studies that were done, both funded under our mechanism as well as others, and they didn't really find strong evidence for new or innovative methodologies. So when you're thinking about study designs, what they see is a lot of parallel randomized trials, pre and post, things that are taken from other disciplines and other areas that, and not really adapted to these settings. And I think many of you will be, it won't come to a surprise. It's really, really hard to just use a, cluster randomized trial in a lot of settings and hope that all your protocols that you outlined at the beginning will be true while it's being implemented. And so I think this is a little bit of some thoughts on, there's a lot of aspects that maybe need some innovation. And the next couple of slides, what I'm going to do is just go through 3 different kind of evaluation parts of the evaluation design, and just sort of give a little bit on what it is, maybe where we have innovated a little bit or thinking about it, and maybe where additional work can be done. And so the first one is around sample size, and I'm sure everyone is very familiar. That's always a big thing in thinking about when you're designing a study, is how many people do you need to enroll? And as Adam mentioned, for Myanmar, it's a cluster randomized trial. And so villages were clustered. We're doing a pair match design, and the primary outcome was adherence. So you can just take your favorite statistical book, and here is a page, maybe from Moulton and Hayes, that gives you a formula for how many clusters or how many villages needs to be randomized and how many individuals within those villages needs to be randomized. And you might get some answer from this. And my experience is that this is typically going to be underpowered because there's a lot of challenges that are going to occur during that study. Loss to follow-up, both of individuals and villages, differential data completion maybe by the intervention and control communities, and a lot of other complications that are going to be arising. And so this formula is never going to be able to take into account all of those complexities. So one place that we sort of are working, and with the Myanmar study, is really thinking about, okay, so we know that we want to look at a lot of different scenarios. So what we're doing is more of a simulation-based approach. So we start from, what we know the data is going to look like. We generate complete synthetic data, multiple instances of this whole trial. We do the entire analysis with this synthetic data, and then we're able to manipulate this synthetic data on what we think might be happening in the trial. Maybe villages will disappear. We'll lose that whole collection. We'll be missing a lot more of different types of individuals. So we sort of can play out these scenarios to understand not only what is going to be our sample, our power, but under all of these kind of alternative ones, just to make sure that the trial is going to be robust to a lot of different things. And so here's the thing, as Adam sort of pointed out, about 50 villages, as everything goes well and everything is great, this is what we're hoping to see. But then we can play these alternative scenarios, is by taking that synthetic data that we sort of generated and being able to manipulate it, having missing observations and things like that, to run alternative scenarios. And so that's one approach that we think might be very effective in sort of thinking about thinking about power calculations and sample size considerations, is to think beyond just that formula and think about more deeply on how you can sort of really make sure the study is robust in terms of that. And obviously, another consideration is that these settings are all very, very unique. And there's a lot of considerations that need to go into that in context. But part of of what you want to do when you generate research is that you want the experience and good practice to be shared across multiple settings. You want it more generalizable, not only to the study population, maybe your population of the broader of interest, but also transportability, meaning that you can take what you find in one setting and think about how that impact is going to happen in another. So you don't have to always run more and more and more trials. And so where we think could be or very useful is going back to that causal loop diagram that was generated. And that's really about all the mechanisms that go through from your intervention to short-term outcomes to long-term outcomes, et cetera. And if you can sort of build and understand what those processes are, that is one way that you can start making how you can transport it from one setting to another, because you understand, okay, this mechanism lives here, but maybe it's different here, or maybe they're similar. And so what you can start doing is taking these causal loop diagrams and building mathematical models to represent that system. And maybe you won't know all the details from one setting to another, but you can start picking out like what is exactly different. So you wouldn't just end up at the end of the day, oh, the effect size is this, but rather maybe thinking about all of the mechanisms so you're able to sort of say which ones port over and which one don't. And so there's been recently a good amount of work thinking about these mathematical models and how they can be used for generalizability and transportability. To still remain those kind of that causal factor, what is going to be the impact of your intervention. And the third thing that I wanted to talk about is the actual study design. And obviously, two broad categories. You can have observational studies, or you can have randomized studies, and I think one can debate the merits of both, but I think very often, at least, people view randomized trials as the gold standard, and that evidence that you get from a randomized trial has more weight, and so that's the gold. I don't know if gold actually weighs more than silver, but those randomized trials have more weight. But as sort of discussed early, or what I mentioned early on, it's very hard to, hey, this is going to be your protocol for your randomized trial and never divert from that. So that's the standard way, is you design your trial, you execute, you conduct your trial, and then you analyze that. And along that kind of conducting it, things change. And what might be necessary is there's been a lot of work around adaptive trials of recently, not really ported over to this complex setting, but I think there's a lot of potential areas of innovation using more adaptive design. So seeing what happens in your trial, seeing what's not quite going right, and adapting it. But you kind of have to have this pre-specified on how you're adapting and what are the markers to do that. But I think that might be a very promising approach to thinking about study design in these settings. And so I just wanted to leave with a couple of conclusions. And this is, one is thinking about that new and innovative methods is really necessary, instead of just porting out what is already out there for, large clinical drug trials and using it in these settings. It might be necessary to really think about developing methods that are specific to this setting, and obviously that'll take time, money, and energy. And as Adam mentioned, thinking about the effectiveness and their cost effectiveness of these interventions is going to be very, very important. And the last thing is just sort of thinking about this recently, in the last, couple years, thinking about the role of artificial AI might play in thinking about study designs, and some people have been thinking about that. And I don't really have an answer whether that is going to be a promising field or not, but just wanted to throw that out there.
Mic on? All right. So at this point, I mean, we could pose questions to each other, and you could, hear us go back and forth a little more. But I'd love to hear from you guys, right? I think we really are interested in your take on what we've been talking about, and to hear your experience, perhaps managing cardiovascular disease or other chronic conditions in difficult settings, whether humanitarian or not. And I didn't get any prompts, but I do see there are 2 mics there. So I believe if you want to ask a question, if you could please walk up to one of those, and since the queue will be out the door, I'll plan to toggle back and forth, but actually it'll probably be pretty easy. Yeah, please. And maybe introduce yourself too, please. Thanks.
Yeah, happily. I think that's on. Good morning. I'm Bethany Hatt-Gauthier. I am a biostatistician. I actually train with Ravi, so really happy to see our discipline represented. Ravi, I have a follow-up question to you, because you're singing my song that, yes, we need to be more innovative in the methods that we pursue. However, in a lot of the contexts where I work, the biostatisticians are already very busy. I can only imagine that the quantitative scientists in humanitarian settings, that's to the extreme, because they've got other monitoring and evaluation needs. So I guess my question is, as we do this innovation, how do we make sure that the new methods are available and accessible and transferable to colleagues who already are hyperextended in those settings? Thanks.
I think you can use this.
That is a great question, and I think there are 2 parts to it, and maybe I'll address the latter. The first one is, everyone, how do you have the time and the bandwidth, definitely, to develop these methods? And obviously, funding is not usually for methods development attached to that. So I think that's going to be a very difficult hurdle to get over. And then the latter one, and I'll sort of just paraphrase and make sure I regurgitate your question right, is even if we do get these methods done, how do we ensure that they can be applied in all of these settings? Because you can't expect people to read massive amount of methodological papers. And I think, unfortunately, both of those are going to obviously come down to funding and time, but I think that what I've seen as a great advance, and not only for in the humanitarian space, but in general in terms of statistical methods, is the requirement to make usable code and reproducibility. And so I think really leaning into that, no matter what methods that we do, is whether it's in genomics or whatever, or humanitarian space, is really leaning into, as biostatists, is always making not only code available, not the analysis available, but really making usable code available. And I think that's going to be critical. In terms of the development of methods, if you have ideas, Bethany, how to get funding to do it, or anyone else, I would be very open.
I was just going to say, Bethany, I still remember when you taught me about lot quality assurance sampling, and I'm so grateful. Thank you.
If I'll just chime in very briefly, I mean, to link to the larger conversation that I'm sure will be going on over the next several days here of decolonizing global health, and I think the localization movement here in the humanitarian sector is trying to be in the vanguard. There's a lot of efforts being put in, and we can talk about how that's succeeding or not. But the capacity of many local partners that we have, even in very unstable settings, is increasing, all the time. And the goal of teaching ourselves, if we say we in the West and the North, is to teach ourselves out of a job. I mean, let's all commit ourselves to redouble our efforts so that there is the technical capacity in the humans who are actually on the front lines here. Next question.
Thank you. Adam Levine, Associate Dean of Global Health Equity at Brown University. I really want to thank all of the panelists. This was really interesting and exciting. Maybe it's just because I'm a nerd about these sorts of things, but it's really wonderful to see people thinking about new and innovative ways of doing research in humanitarian contexts, because we don't have enough of it and we need more of it, and we're only going to get it if we think about how we can do it differently. I have so many questions, but I'll limit it to just two, one for Ravi and one for Adam. So first for Ravi, I've been involved in a number of different adaptive randomized controlled trials, mostly related to Ebola, both in West Africa and in DR Congo. And one of the issues that I have faced in the real world implementation of these trials, which nobody talks about, is the fact that an adaptive trial can only work if somebody is reviewing on a very regular basis the results and adapting it. And typically with trials, what's almost always required is a separate DSMB that's going to be reviewing the trial. DSMBs typically in a regular trial in a stable setting meet once or twice a year. I've never seen a DSMB meet more than once every 3 months or so. And when you're only meeting once every 3 months, that doesn't give you the sort of ability to see where things are not working quickly enough to actually adapt the trial and change it in a reasonable amount of time. And so I wonder, is it just that we need DSMBs to work harder, or are there other methods that we can use or build into the trial to trigger automatic changes that don't require sort of DSMB input? And then my second question for Adam, I really enjoyed learning about these methods for analyzing not only the effectiveness or cost effectiveness of a study, but also building in the equity piece. But I imagine, because whenever you do subgroup analyses, it increases the sample size that you need. This must increase the sample size that you need in order to get these effects. And so do you have methods for understanding how much it increases the sample size? And also, you gave examples that just look at education or just at income, but obviously inequity exists on multiple dimensions. And so each added dimension, I imagine, must increase sample size further. So how do you decide which dimensions to actually build into this when you're looking at inequities and calculating them? Thanks.
Yeah, no, in terms of the adaptive designs, I'll throw out another one as a complication is not only how long does it take to get it reviewed at the peer, but a lot of these trials may not even last, you may not have a year, or it's not the same as a clinical trial where you can maybe run it for 2 to 3 years. So I do think where some of my thoughts are is that it would have to be it has to be pre-specified in automatic changes, that you can't wait, and you can't wait for that amount of time, and how to best do that, I think that's going to take a little bit of methodological development. So I wish I had a better answer for you at this moment, but I think and maybe a little bit around where I was thinking AI could be helpful is that sort of faster processing of what is going on than we can do with standard methods.
Great. Thanks, Adam. And I heard two different pieces, I think, to your question. So one is just on although they're related, but the overall sample size increasing if you're looking at the distributional effects. And so I would say under a frequentist worldview, and even under a Bayesian framework, that's probably true. That said, you still, like when we decided to power the study based on the primary outcome and to look at the differential effects and to see where the data led us, being the first, to our knowledge, example of this, certainly in a conflict setting. And I think resources that are put into services and also into research, you got to think carefully about sample size. I will say our initial sample size though would have been sufficient to look at that. I'm not aware of easy tools to look at that, but actually, if we wanted to look specifically, like empirically, at what the likely impact would be of different scenarios, well, the simulation approach that Ravi was talking about would be a way to do that, to say how much might we need to, if we did want to really focus on that distributional, impact as the primary thing we're looking at, we could use the simulation approaches. And I would say the same thing on the back end, that's how we plan to analyze it. That's how we did it for the 2 trials here in Los Angeles County for stroke. You take simulation-based approaches because there's uncertainty from different sources that you need to take into account. I would say which dimensions, so you're exactly right, multi-dimension indices of deprivation are now, thankfully, right, being promoted by CMS here in this country, and I would say are underdeveloped in the humanitarian space, right? What is shocking to us is that even looking at the bivariate associations of any one of household wealth, barter economy, where there's very little income, that tends to work a little better. I threw up education just as an example, but that we do see those. I would say though, what would the impact be of a multidimensional measure? So borrowing from, to get not too technical here, but when you're looking at heterogeneous treatment effects, then it is often, you increase your power by a lot if you take multiple dimensions into account at the same time. You can think about this as like a traditional forest plot of looking at the different subgroups one at a time, but these things again often cluster together, and when you take into account these things together, it works. So cardiovascular disease, if you say, well, you have do or do not have diabetes, was it more or less effective? If you had high, if you're older or younger, was it more or less effective? Well, if you look at it as cardiovascular risk and plot out, right, the heterogeneity of your treatment effects, those analyses have proven to be much more robust and then precise, right? Your estimates will be more precise. So I think you're right to encourage, greater development of these multidimensional indices of vulnerability in humanitarian context. Next question.
Thank you very much. David Heller. I am a internist as well as an implementation scientist at the Arnhold Institute for Global Health at Mount Sinai in New York City. I'm privileged to work with some incredibly talented scientists from northern Ghana on a cardiovascular and actually mental health joint intervention related to community health workers in a low resource, although not politically unstable setting. And I think the question that stood out to me that I'd love to hear a bit more about, because it's what we're grappling with, is what are the practical and to some extent methodological ingredients of the CHW package, right? So for example, is it motivational interviewing around helping people to understand why and how to take their medicines? Is it those kinds of techniques or others related to tobacco cessation or alcohol reduction, which is a major cause of cardiovascular risk? And in particular, because I don't work in humanitarian, unstable settings, how does that relate to mental health? Because I imagine that mental health, even as we're seeing in Ghana, but especially I would imagine, in displaced individuals, is a major stressor and a major contributor to cardiovascular health. So sort of how does that work in terms of what the CHWs actually do?
Sure, I want to make sure I understand the question. So essentially, what are the core components of a kind of a successful, I guess, do you mind, because there's an echo and I didn't quite hear everything you said.
The specific practical question is, what are the actual elements? And are they based in specific sort of research methodologies or proven techniques like motivational interviewing? And surely it varies, right, depending on the setting. Work, is it motivational interviewing, is it counseling? What do the CHWs do?
Yeah, it's so interesting that you mentioned motivational interviewing, because that's actually something that we used in Jordan with Syrian refugees. I didn't go into this is a bit of a sidetrack. We actually developed our entire intervention with, the goal was going to be to include, I'll tell you what I think the essential components are. How about that? And I do think it varies from setting to setting, but I think adherence, is one. Medication adherence. I mean, we would love for everybody to change their lifestyles, change their diets, get that exercise, and do all the things that you need to do to, enhance prevention of cardiovascular disease. We know that the reality is in all settings, but particularly in, low-income settings, in unstable settings, it's incredibly challenging to do that. So medication really becomes a big piece of that. So for me, medication adherence. And then I think linkage to care is a really important piece. So one of the other pieces that the community health volunteers were trained in, and are trained in our current research projects in Myanmar, is screening for complications, right? So, essentially ensuring that when somebody needs care, they can get it. And then, finding some way to bring some elements of that clinical care to the patient that, that they otherwise wouldn't be able to get. So, for example, both for Syrian refugees and for the individuals working within Myanmar, very challenging to make it to a clinic to have your blood pressure and your blood glucose measured, right? So, that's an easy thing to do. You can sort of give them that power as well. And then creating a tight loop with the clinic so that I feel, hopefully I'm not giving you an incredibly basic answer, but I think really tightening up that loop and making sure that piece is well designed. Harder than it sounds. And I think the other piece is an kind of that iterative approach as well. Where when you're sorting out the thing, you just have that ability to have the adaptability kind of as you go along. Trying to think if I'm missing anything else. I will say the motivational interviewing piece. We trained our CHVs in this when we started this intervention, and then COVID hit, and we were unable to do the intervention as planned. And what was interesting is it became just medication delivery, adherence, screening for COVID, screening for complications of disease, and linking people to care. And the CHVs did it anyway. It was really interesting. They really worked with them on it. And it was very, it's one of these things. There were enough, I don't know how much across the board it made a difference, but there were pretty significant stories of people that quit smoking, lost a ton of weight, really had some lifestyle change. So I'm a big believer in that.
And I'll just chime in for mental health. So stay tuned, but R2HC has funded IRC working in Mela camp, which is located in Thailand, with Burmese refugees, to use CETA, which is a proven method for group-based mental health therapy developed by folks at Hopkins, Judy Bass and Paul Bolton, and used, trialed in Uganda and Myanmar and several other settings, right? So they're using that to improve adherence in the camp to CVD therapy. So stay tuned for their results. I've heard that they are good. Maybe not overwhelming, but but good. I think changing lifestyles becomes pretty challenging in a lot of these settings, but those messages, certainly are part of the ticket. And I would, for people who are in the business of applying for money, the Global Alliance for Chronic Diseases, GACD, has a call that will soon have the NIH flavor added to it for multimorbidity, and mental health and CVD is something that I would love to talk with you afterwards about.
I'll just add one more thing, and that is, please sit if you'd like. Don't just sit. Safety, I think, is a big piece. So, particularly when you're in a setting where people are quite remote, just ensuring that your community health volunteers, when delivering medication, when assessing for side effects, when, just ensuring as you're extending these interventions that you're catching the patient, you're really catching it if a patient has an adverse event or something like that. And we run into that. And there's great ways. If that ever comes up, I'm an expert in that, and I'm happy to talk to you about that.
Please.
Good morning. Thank you for your presentations and the work you do. My name is Fiona Strasser-King. I am a clinical cardiologist at UT Southwestern in Dallas, and I do some work in healthcare delivery and medical education in Zambia. My question for you, Praveen, with your work in Jordan, we talk about health literacy with a patient, about how patients are not compliant and all that, but the responsibility for health literacy falls on us because we can expect people to know what we don't teach them. Do you have any examples or gains that you have made in that arena, or guidance on how we can improve on our health literacy delivery and outcomes on how patients do when they know what's going on?
Okay. And I don't know why I'm not hearing all of the questions completely, but I think what you asked was what kinds of resources are available to ensure patient kind of adherence to care, or am I missing it? Say it again.
Well, more health literacy.
Health literacy,
I think that's the basis.
Okay.
When patients don't understand what's going on, then they do not comply and they do not adhere. So do you have any strategies that you have used and any outcomes there to show that patients do better when we focus on making sure they understand the concepts of the basis of their disease?
Yeah, thank you. This room is very echoey, so I'm hearing so I appreciate you repeating the question. We did several different strategies, and it was interesting because we did have to flip this intervention to address COVID pretty quickly. So a lot of the traditional things. So we had, actually we had a fantastic artist that put together artwork with captions in Arabic, and that was something that the community health workers could actually use to have discussions with patients. I think one of the really beautiful things about the CHVs and CHWs is they have time. You know, they can actually, if you give them some core messages, they have time. They're from the community. They understand how to talk to people. One of the things, I'm certain I'm stating the obvious, but one of the things that happens in healthcare settings, we do this all the time in the United States, is patients come to us and then they feel like they're getting a lecture. Nobody wants a lecture, you know? The question is, you know, and so I think this is where motivational interviewing comes in, and you can kind of use it in a way that's fairly subtle, which is, well, what is it that you enjoy about your life? You know, what are the things that you kind of want out of your life? You know, well, I have my grandchild, you know, I really want to see my grandchild grow up. Okay, let's talk about your cardiovascular risk. You know, how can we work together so that you can spend more time with your grandchild playing to get that exercise? You know, whatever it is. And so I think the CHVs are really, and community health workers are very good, if you train them well, in making messages relevant and less lectury, and giving patients an opportunity to say, in a setting where they're not going to be judged, I'm having a really hard time taking my medicines, I kind of hate it, and then strategizing. So that's my hopefully not too obvious answer.
I'll take the prerogative of, to also add just a couple comments, is that this is in part based on my experience with malaria, which is a lot simpler than cardiovascular disease, but then treating cardiovascular disease. I mean, humans have this amazing ability, right, to hold very different ideas in our heads at the same time. And I've found it useful to really promote, right, the positive messages as opposed to convincing people to forget about, you know, messages that might be wrong. At the end of the day, what we need is for them, right, to recognize the value of taking this pill. And if they think there's other causes of their blood pressure and they need to do other things to address that, you know, if you're treating malaria, you think malaria comes from a papaya or some other fruit, do I care? Only if it prevents you from, you know, going to get tested and taking, you know, and completing your treatment, right? If you have a fever, and I think there's a tendency sometimes to want to like impart all this, you know, complicated stuff that we as clinicians and physicians, we're the worst, right? So, you know, because we've just been fed all this information and we try to, it's way too complicated, right? And I think Parveen's point is spot on, right? The folks who know how to titrate that message are the local folks, right? So the value of community health workers really stands out, I think, in this communication piece. They know when to push to get people, you know, to maybe change a barrier, right? An idea that might be a barrier to treatment, and when to just like let it go, because people can hold both of these things in their head at the same time. I'm gonna go to the back microphone because I think you've been waiting patiently. Thanks.
Thank you so much. This is Nada Fadal. I'm a professor of infectious diseases and assistant dean of DEI at University of Nebraska Medical Center. But my primary global work is focused in Sudan, where we had a community medical response team that we established during COVID-19. And at the time, we chose Project ECHO as an implementation strategy to create a learning collaborative so we can train these community health workers. The only difference is that these community health workers are from medical background, so they're all either in the healthcare field as professionals or students. So their intervention then would be to go and actually do medical interventions in the clinic, like mobile clinics, vaccine distribution, etc. And this team is now active in the war in Sudan, doing somewhat similar to what you have been describing, because we had seen a sudden increase in sudden deaths in displacement and refugee camps. So I wanted to share that backstory because my work here in the US is focused on health service and implementation science research in HIV. And what we've learned from that work is that looking at the early phases, even pre-implementation, implementation, what strategies, why these strategies work, is extremely essential. So I was wondering whether you had considered like a hybrid type 3 type of study where you're looking at the implementation outcomes, but also the effectiveness of the intervention. So.
Yeah, thank you for that. No, absolutely. And one thing we didn't talk about was the use of implementation science in both of the studies that we talked about today. So We used, we actually have a plan to implement with our cluster randomized trial. We're going to be using the REAIM framework to actually look at the implementation of the study. I think it's just so critical when you have an intervention like this to look at it from that perspective. So absolutely, and there's obviously many different possibilities and kind of how that can be used. In cardiovascular disease, I think a really good example of it is Ivy Nansborough again did this in Jordan with the MSF cohort, and she has a really great publication. I can't remember which journal it's in, but if you look up Ansborough Implementation Science Jordan, you'll find it. It's a really good read. We're at time.
Yeah, I think we're at time. Personally, I'm happy to have another conversation, but I believe we probably should wrap it up. So maybe if there's anyone else with a question, we're happy to speak with you offline. Thanks to all for your active participation and just for being here at 8:30 in the morning. It's really great, and I wish you the best, most successful conference, and excited to follow up with anyone and everyone afterwards. Thanks so much.